No? Thank you. So our mission as a coalition is to probably going to be the same across the country, but basically to enhance the capability and capacity of the healthcare system in North Idaho and improve collaboration, communication, and coordination, those 3 C's. We do this with all partners. And the reason I wanted to highlight that is we realize that we need to have our entire community up to the table to be able to respond and then recover, and that is a really important asset, and I think we all know that. The purpose, basically you can read that, but we support our emergency manager, our ESS 8 functions, and our preparedness plan, recovery, and response. Currently we have 9 members on our Healthcare Coalition Executive Committee. I have 2 open spots right now, so I'm working with 9 professionals. Hospital, EMS, fire, emergency manager, public health, tribal. We have a mental behavioral health representative, volunteer agency, skilled nursing, long-term care representative, and we've just switched it up a little bit. We've added an access and functional needs representative. We feel that having a wide range of disciplines at the table is really going to help our coalition to make the correct guidance decisions for our arena. We might not need them all at the same time to give us direction in one avenue or project that we're working on, but as a community we all have to come together, so this does give us the subject matter expertise. Within our coalition we do have a governance document. It's our charter. It is inclusive of a MOU, very general MOU. I think we actually borrowed it from Region 9. Play nice in the sandbox together. You know, we'll share resources if you have it. Other than that, it's a very general overview. We do ask that our partners come to at least 50% of our meetings. We ask that they participate in training and exercises, and we do ask that they participate in work groups when their subject matter expertise is needed. Currently, this is a listing of our participants and members. We have 4 out of our 5 counties have emergency managers. 2 of them are full-time and 2 are part-time. And you can understand the challenge with everybody wearing different hats. So our emergency managers are one of our foundation people, and so I lean a lot on our 2 full-time emergency managers. We have 5 ED hospitals in our region and 3 non-ED hospitals. We have 4 EMS agencies within our region, and then our 5th county is strictly run by volunteer EMS. And you can imagine the challenge that is to even get them to the table. Even when we go to their table, they're either working their full-time job or they're running an ambulance. So surgical centers, we do have surgical centers involved. Our community health centers are involved. Tribal nations are totally at our table all the time. We're very appreciative of that. Can't imagine doing the work without them because they have their own population density and challenges that if you don't live there, it's hard to understand them. Volunteer organizations, just as an example, the ARC, VOAD, they come to the table. We've just had communications with the Kroc Center to continue that relationship with the Salvation Army, which is a wonderful step. Community service agencies, the dialysis, the durable medical equipment, just like Michael was talking about in the state of Washington, we're trying to also focus on that. Hospice and home health services, I feel that that's a really strong partner to have in your toolbox. They have a lot of clinicians that can come in time of disaster. They also, we need them to be self-sustainable. We don't, you know, again, our mission is to alleviate the pressure off the EMS transports and the EDs. So if we can keep them healthy and still servicing their clients that are in a lot of rural areas for all of us, I think that's very important. Long-term care and assisted living facilities, again, a great resource, I think, in our toolbox. Not only are they able to take certain levels of patient care, they're a wonderful offloading facility to have for hospitals. And recently I just learned through some federal training that through different waivers, regulatory things that can be addressed, they can take direct patient admissions directly from site. So you could do it direct from triage to long-term care with certain regulations being waived. Access and functional needs services. We have people from the Idaho Commission of Blind, Hearing Impaired, and Deaf, Disability Action Center. If you're going to plan for these people, you need to have them at the table, and they need to be actively involved in your exercises. Mental behavioral support. We have our Department of Health and Welfare is a strong partner of ours within our region and within the state of Idaho also. They have really come to the table in the last couple of years. They've developed more plans. They've always been there. We've always counted on them. But now we're really working strategically together to see where else they could fit, whether it's a family assistance center, just continued bereavement support for victims, or for health care and first responder support. School districts and higher education, we have them come to the table. Certainly in Kootenai County, we have the Coeur d'Alene School District. They attend on a regular basis. And then we have NIC that does come to our table a lot too. The representatives there, one from NIC works directly with the student population with disabilities. We also work with the nursing school at that location. And then, of course, we have our regular relationships with all the school districts in our entire region on a public health vision as far as being able to inoculate and set up pods and disperse medications if need be. So we use them in our plans. Federal, state agencies, FBI shows up once in a while, the Bureau of Homeland Security. It's always nice to be partners with them. And our coroners, I'm very proud and give a shout out to our planner, Alana Anderson. She has worked very hard in the last 3 or 4 years on a regional mass fatality plan that has been accepted by all 5 counties. And currently we have a new coroner in Kootenai County, and they are very eager to test this plan full scale next year during Cascadia Rising. So we look forward to that. And of course law enforcement and then public health. We have changed a little bit up as far as our meeting schedules, and when we ask our partners to come to the table, we're trying something new this year. We're going to meet 2 times a year as a large general meeting, and then we're really moving into much smaller focused work groups. These will be project specific or plan specific. It will lessen the time and burden on our hospitals or subject matter experts that have to come quarterly to a long 4-hour meeting, and if we can have them come maybe every other month to a quick 1 to 2-hour meeting, work on a project, and then move on from there. And then at that point, the work groups will report back to the coalition as a whole as to their progress that they've made. So we have a healthcare work group, and it's mostly hospital-centric, although we do have EMS experts come in. And we're very fortunate in North Idaho that the hospitals themselves have been working with a consortium, through the hospital consortium. They have a Northwest Alliance group, and within that they have peer work groups that get together. They have a emergency preparedness peer group that meets directly, and it's our 5 ED hospitals. They're currently reviewing our regional plan. They're going to work on some projects for us, so it really gives them the ability to just the 5 of them or 6 of them sit down and work on something and then get back to us, and we can go from there in our planning. We have a chaplain and ministerial work group that's been meeting for about the last year. We're very fortunate that we have an active chaplain at Kootenai Health that's been working with us. And then from there, we have Mike Bullard from VOAD lives in our area, and he has gotten together with a number of other chaplains within our arena that have live experience going out to different missions and different response disasters internationally. And the focus of this group right now is to educate other ministers and chaplains within our arena that can help support the community throughout a disaster. And that can be in any level, whether it's in your facility as a hospital, your community, and of course then we ultimately want them to continue to educate their own congregants. Again, the philosophy is if we can educate the people out there to be self-reliant, more so than they are already in North Idaho, be prepared, be able to help your neighbors. Education is key. I mean, we all know that. So it's a great group, and they're very responsive. We're looking forward to working with them. We also have an at-risk access and functional work group. This is one of our first work groups that we had, and we pulled a lot of different disciplines together, if you will. We had, Commission of the Blind and Disability Action Center in the school, and just a group of people. Basically, it was all non-hospitals that we ended up with. What their goal was to develop an educational tool. Through talking with the representatives, we found that some of them had educational material, and they actually had processes in place that when they had an intake with a client in whatever capacity that was, some of them would give them education on emergency preparedness. And then there was a larger majority that did not. And again, education is key, so we've developed a tool that they can brand themselves. It's not via the health district, but it's a blanket flyer that they can give out and add to their arsenal of things if they already have a process that'll help educate them. So when the fires happen, and we're trying to decide if those 5 residential homes that have 2 or 3 clients in them, are they already prepared? Have they evacuated? Do they know what they need to do? So again, another great tool. And then that led into more of a situational awareness tree where during the fires we used our partners that service these clients to find out immediately, as you did also, Travis, what's your status, what's your client status, do you need help, what can we offer as far as getting information to our emergency managers as far as evacuations of the town or the facility. So it's worked out well. Skilled nursing and long-term care. I just started this work group with one of our long-term care directors in our region, and we are going to be taking a readiness survey of all of our facilities. We find that in our area we have about a half a dozen large facilities, and then I have quite a lot of 16 to 20 bed facilities. And I'll venture to say that most, if not all, have some type of plan. We know that they at least practice their fire drills, and we know that they are at least in the parking lot. But where do you go from there? And so that's what we want to assess is, what plans do they have? Where can we help you? Where can we support you? And then do you want to roll in the community response, or do you just want to be self-sustaining and shelter in place, or your choice? But at least let's educate you and get you to where you need to be. And then one of the last groups we had is a WebEOC work group. Dean Keck from our office headed up this group with one of our emergency managers. And they built a all-hazard situational awareness board that we've piloted for the state of Idaho. It's active in Region 1. We have used it throughout the year. Hospitals and other partners can sign up to receive email notifications at different levels of red, yellow, green, depending on the severity of the notice. And they'll receive an email. It's a great tool. We had a small landslide going off to Harrison around the lake. It closed the road, and which meant that our EMS services had to go a totally different route around the lake. Well, this definitely adds a lot of time to your travel when you're trying to get to the hospital. So it also includes a resource board, not quite as robust as your manual, but I might be looking to you, Lena, for some help on that. And then document sharing. And if you're familiar with WebEOC, you see that you can just upload a document to that. So we are not in Kansas anymore. What are our challenges? Well, we don't have the money. You know, that's the bottom line. And unfortunately, it seems to be that that has been a large carrot that was used for quite some time. And I'll just leave it at that. Geographic diversity. We are very similar in geographic situations as you are here outside of the Spokane area. I mean, we're fairly rural. I mean, outside of Kootenai County, everybody is fairly small, 25-bed critical access hospital. We have a broader participation, and that can be a double-edged sword to us. It's not centric on just hospitals and EMS and emergency managers anymore, but we feel that controlling the breadth of our involvement with the community response partners is going to be key. We have learned very graciously from our partners here in Spokane, and so we're aware that we don't want to spread ourselves too thin, but we're a much smaller population base, so we don't have quite the same challenges as you do. History. We have a lot of history here. There's been over 12, 13 years now of money coming in, people working on infrastructure. They have built up their plans. They've got decontamination ability, and they do a great, great job at what they do. And so some things, they're ready. Educating new members. We do have to do that. We do have to educate our new partners at the table. And then what's in it for me? How do we keep them engaged? And I think every coalition is going to have that challenge. So the year ahead, we're going to try to keep them engaged by bringing in speakers, doing trainings and conferences. In Idaho, the ask for grant money is now referred to as training and exercise money. It is on a very small comparison basis this year. I got $18,000 to spread across 5 counties, and you can do the math. There's not a whole lot of money there. So we've been working some ideas with the executive committee, and we're not making any major changes this year, but we're going to look at trying to offer some better education and trainings to the community as a whole. You know, if there's something specific, if it's a NIMS compliant for a hospital healthcare facility, certainly we'll look at doing that as a priority. But I think we need to bring a broader spectrum and bring in some good speakers and education. Work group focus, I've already gone over that. We've also started a newsletter. Region 9 has previously had a newsletter, and we enjoy reading that. Maybe that'll come back out. But it's one of our tools that we're going to use to share the information that we have to continuously share on an every year basis, and you don't need to sit in a meeting for 2 hours to hear the same thing you heard about communications every year. We can do that in another medium. Second tier, healthcare education, roles and responsibilities. I spoke about that. We know that they're there. We know that we can use them, and I think we talked about that earlier, use the whole system. Exercises. North Idaho, Region 1 and Region 2, the top 10 counties in Idaho are very involved in Cascadia Rising, and so we are in play there. The state of Idaho is in play with Pacific Northwest and FEMA Region 10, so where you will be testing. And then regional goals, we had a statewide jurisdictional risk assessment that the University of Idaho provided for the state health districts, and we are going to try to get some more robust information from our community partners to try to look at the healthcare gaps that we have. And with these real events happening, with the fires, measles, and just different circumstances in our life, I think we can learn from the lessons. And so we appreciate everybody sharing their lessons learned, even if it might be uncomfortable, but I think we don't need to reinvent the wheel again. And as Michael alluded to earlier, we need to find a new way to measure our healthcare coalition. We can't really use the old standard anymore, and so we need to find that. And then the resource book is my last goal for this next year. So any questions I can answer for you? Oh, all right, thank you.